Hi, my name is Amanda Constantino, and I'm a DNP student at Nova Southeastern University, and this is my DNP Project Defense. My project is Increasing Self-Efficacy and Bystander CPR Rates, a Train the Trainer program. My project chair is Dr. Henson Everts. So over 420,000 out-of-hospital cardiac arrests occur each year in the United States alone. However, only 46% of individuals in these cases receive bystander CPR, which is BCPR. So bystander CPR is compressions only without breaths, and this is an initiative that the American Heart Association pushed out around the year 2010 to try and increase the bystander CPR response rate. So they actually found numerous benefits to bystander CPR, including improved survival rates, decreased brain damage post-cardiac arrest, and improved patient outcomes. They actually found that only doing compressions with no breaths at all still tripled somebody's chance of survival. So they've been working on this goal for a while now, and they've tried to come up with some innovative ways to train the public. In my photo here, you can see a little kiosk that the American Heart Association put in some of the airports across the nation just to try to get the public involved and to get more people trained. However, despite all of the efforts, only about 30% of the population is currently trained in bystander CPR. So the problem is that there's a lack of structured training programs designed to increase bystander CPR rates for out-of-hospital cardiac arrests, and so the number of individuals trained continues to be low, even though we have plenty of evidence showing the clear benefits of bystander CPR. The purpose of my project is to increase the number of community members in underserved areas in Central Florida who are trained in bystander CPR, to increase self-efficacy levels of community members trained in bystander CPR to deliver bystander CPR, and to develop and implement a Train the Trainer program for community leaders to maintain increased numbers of bystander CPR training. My project is modeled after Bandura's self-efficacy theory. So self-efficacy is an individual's belief that their actions are capable of making an impact in a given situation, which can be a powerful motivator for learning. My project objectives are to identify community leaders to be certified as community BLS instructors, to develop and implement a free Train the Trainer BLS instructor program for 5 candidates, to implement collaborative bystander CPR training event in an underserved area of northeastern Central Florida, to evaluate the effectiveness of the Train the Trainer program, and to measure bystander CPR training participant self-efficacy levels before and after training in order to look for statistically significant differences. In reviewing the literature, there were several themes that became apparent. First, free, brief, community-based bystander CPR training was found to be just as effective as taking the full courses, which are typically hours long. It was also noted that specific areas can and should be targeted, such as lower socioeconomic areas, areas with lower education levels, and areas with high rates of out-of-hospital cardiac arrests. Higher self-efficacy levels were linked to better performance during resuscitation events, so this is an important component of my project. So not just training community members on how to perform bystander CPR, but actually increasing their self-efficacy or confidence levels to deliver the bystander CPR. Lastly, common barriers to delivering bystander CPR during out-of-hospital cardiac arrest, such as contracting a disease or the fear of being sued, are actually reduced through bystander CPR training. My first study by Baldi et al., they measured participants' compression quality using automatic feedback devices. So these are now a standard in resuscitation training. So a mannequin or device that has automatic feedback includes an auditory prompt, which is usually a click, and that lets the participant know they're hitting the correct depth, and also a visual prompt, which is usually a light, and that shows the participant that they're compressing at the correct rate. So I'll be using automatic feedback devices during all of the community trainings to ensure that they're being able to perform high quality bystander CPR skills. So what they found in this study was a statistically significant difference in comparing the groups that used no feedback versus short feedback and no feedback versus long feedback in terms of correct hand placement, chest recoil, and depth. So the implication from this study is that shorter practice times are sufficient to be able to train community members in bystander CPR. Bergamo et al. Targeted bystander CPR training to specific geographical areas in Texas, and this study was one that I modeled my project off of. So what they did was enlisted community leaders who wanted to teach bystander CPR to community members, and then they had the instructors just borrow a kit that they made, which included mannequins and training supplies, and then the instructors went out into areas that were known to have high rates of cardiac arrests and low rates of training in order to try and increase the rate of people trained in bystander CPR. And these were quick training sessions, which they said took only about 10 minutes, so the program was called Take 10. And they did find that the mean incidence of bystander CPR performed in those specific areas that they targeted increased. So the implications from the study is that involving community leaders increases bystander CPR rates. Bolin et al. Did a study to reduce the barriers to bystander CPR performance. So they found statistically significant differences before and after training that individuals were more likely to perform bystander CPR in a stranger, they were less fearful of diseases, and they were less fearful of being sued for performing bystander CPR. So the implications from this study is that training decreases associated barriers to performing bystander CPR. Charlier, Vanderstock, and Iserbert did a study on the effectiveness of peer-assisted learning to teach basic life support CPR skills. So they divided up a group of students, and instructors taught half of them compressions and the other half ventilation skills. And then they paired up students from each group who had just learned compression skills and the other half of the students to see if peer learning was an effective method of learning. So they found that there were statistically significant differences between the groups in regard to correct chest compression depth. So our implications are that peer-assisted learning assists in maximizing learning and reinforcing knowledge and skills learned. Gonzalez Salvato compared compression quality in healthcare providers versus laypersons during a health fair event. So they had participants practice on feedback mannequins, and then they tested them for 2 full minutes on chest compression depth, rate, and chest recoil. So when they looked at the data they got comparing healthcare providers to laypersons, they found that there were no significant differences in compression quality. So this is actually a good thing because it indicates that free brief training for laypersons is an effective method of teaching bystander CPR skills and that they were able to perform just as well as trained healthcare providers. The studies by Malzi et al. And Sanchez et al. Both measured self-efficacy levels before and after bystander CPR training. They found that self-efficacy levels increased from 41.6 to 100% before and after training and 10% to 94%, and their ability to perform compressions during and out of hospital cardiac arrest. So the implications are that self-efficacy levels can be increased through free bystander CPR training. And a study by Thacker Rivera, they assessed the impact of race and income and educational level on bystander CPR performance and survival rates. So they found statistically significant differences in higher income versus lower income areas, white versus black neighborhoods, and higher educated neighborhoods versus lower educated neighborhoods. So the implications are clear that quality bystander CPR training is needed in underserved areas. So my project is a quantitative before and after design, and it will be taking place in an underserved area of northeastern Central Florida. Participants in the community training will be for adults and high school students who are at least 18 years old, do not have a current CPR certification, and can read, write, and speak English. The community leaders will be trained to be instructors, will have access to underserved groups, and they will also be able to read, write, and speak English. So the community trainings will involve participants completing a pre and post survey to measure their self-efficacy levels to deliver bystander CPR during an out-of-hospital cardiac arrest event, and the instructor training will involve training these community leaders to be American Heart Association BLS instructors with an additional requirement to commit to doing at least 3 free community trainings each year. During the community training, participants will receive a free goodie bag as an incentive to participate, which will include a little water bottle, a CPR Saves Lives bracelet, some Lifesavers candy, and a printed summary of the bystander CPR steps for them to reference afterwards. The incentive for the instructors is to get free American Heart Association instructor certification, and they are also getting free training equipment to conduct their own trainings. My ethical considerations for this project include obtaining university IRB approval, as well as obtaining a consent waiver so that personally identifiable information is not collected from participants. The use of a written consent form would actually be the only record linking participants to the project, so in order to maintain confidentiality, I will be requesting a consent waiver and not collecting any personally identifiable information at all. In addition to confidentiality, the ethical principle of beneficence will be maintained by determining the best way to disseminate bystander CPR training to the public, which will be beneficial for future trainings and positively impact the lives of community members. The ethical principle of non-maleficence was also considered, and participants will be informed of the procedure beforehand. It will be made clear that participation is voluntary, and risk minimization procedures will be taken, such as providing free resources for local support groups and personally debriefing anyone who experiences an unexpected emotional response as a result of discussing or practicing CPR. Participants for the project will be recruited through the use of flyers, phone calls, and emails. The timeline for the project is broken down into 3 phases. So the first phase is the instructor training, which will take place over the course of 2 days, and the instructors will complete the American Heart Association instructor course, be monitored teaching a class, and also discuss bystander CPR training requirements. This will take approximately 14 hours total. Phase 2 is a week-long community training from June 1st to June 7th. This is where newly trained instructors will spend a total of 6 hours or 1 day being monitored teaching community members in bystander CPR. This training will take course over the span of 1 week, and that will be a total of 42 hours. Phase 3 then involves instructors completing their own bystander CPR trainings in their respective communities. Instructors are required to complete 3 free trainings each year as a requirement for being in the project, and they are required to complete at least one of these trainings by the end of July, so the total time span of this DNP project is from May 28th to July 31st. My budget for this project includes items for the instructor training, which is manuals, certifications, and the biggest expense is actually the instructor kit, because each instructor will get 2 of their own automatic feedback device mannequins, as well as 1 AED trainer so that they can do their own community trainings. Additionally, printing materials and the cost of the goodie bags are included in the budget, and the budget would then total $3,157.97. So my 6 objectives and outcome measures are as follows. I identified the community leaders willing to be certified as community instructors, and they would commit to providing at least 3 free classes per year for project sustainability, with an outcome measure of enrolling 5 suitable instructor candidates. 2 is to develop a free Train the Trainer program, which is designed for community leaders, with an outcome measure of following the existing AHA model to become an instructor with bystander CPR additions. 3 is to implement a free Train the Trainer BLS instructor program for a total of 5 instructor candidates, and the outcome measure includes passing the provider exam with a score of at least 90%, passing the instructor exam with a score of at least 84%, as well as passing skills testing and completing monitoring sessions. 4 is implementing a collaborative bystander CPR training for community members in an underserved area of northeastern Central Florida to increase the overall bystander CPR rates, with an outcome measure of training at least 50 individuals to ensure an adequate sample size. I will also be using automatic feedback devices to train community members in order to measure the quality of bystander CPR skills, including rate, depth, and hand placement. 5 is to evaluate the effectiveness of the Train the Trainer program by measuring each individual instructor's bystander CPR community instructor tracking forms, with an outcome measure of collecting data on the tracking form, which includes the number of students trained and the location of the training. 6 is measuring bystander CPR training participants' self-efficacy levels before and after training using the Basic Resuscitation Skills Self-Efficacy Scale, which has been adopted and adapted for bystander CPR training and has a Cronbach alpha of 0.96. These surveys will use a 5-point Likert scale with response options ranging from extremely confident to not at all confident, and a paired t-test will be used to measure for any statistically significant differences in self-efficacy pre- and post-training. A p-value of less than or equal to 0.05 will be used to determine statistical significance in order to be congruent with other similar studies. The implication of this project for nursing practice is that bystander CPR is linked to higher survival rates for out-of-hospital cardiac arrest victims and lower healthcare costs. Victims who have bystander CPR performed during out-of-hospital cardiac arrest also have improved neurological function. In terms of healthcare delivery, involving community members in the chain of survival allows early recognition and intervention of out-of-hospital cardiac arrest event, which this project is focused on by increasing community member self-efficacy to perform bystander CPR. In terms of healthcare policy, Florida is currently one of 12 states that does not require CPR training in order to graduate from high school. So there are over 700,000 students nationally who lack bystander CPR training. At least one of the instructors chosen for the project will have ties to a high school in order to focus training on this population of individuals in the future. There are numerous positive healthcare outcomes that result from bystander CPR. Approximately 45% of out of hospital cardiac arrest victims who receive bystander CPR survive, and survival rates are improved when community members perform bystander CPR. Bystander CPR training also allows for a quicker response rate and superior chest compressions compared to individuals who have not been trained. So my DNP essentials, essential one is scientific underpinnings for practice, and this is demonstrated through the use of Bandura's self-efficacy theory as the framework, as well as gathering evidence for the project. Essential two's organization and systems leadership is demonstrated through the evidence-based intervention of community and instructor training. Essential three is clinical scholarship and analytical methods for evidence-based practice, and is demonstrated by making healthcare delivery changes through the Train the Trainer program. Essential 4, information systems and technology to transform healthcare, is demonstrated by using automatic feedback devices for bystander CPR training. Essential 5 is focused on healthcare policies related to bystander CPR and its impact on nursing in the community. Essential 6 is demonstrated by engaging in interprofessional collaboration with community leaders and community members to improve healthcare outcomes. Essential 7, clinical prevention and population health for improving the nation's health, is demonstrated by increasing the number of individuals trained in bystander CPR as well as their self-efficacy to perform bystander CPR. And Essential 8, advanced nursing practice, is demonstrated by transforming current processes using evidence-based practice to improve patient and community health outcomes. In conclusion, gaps in the literature reveal a lack of structured community-based programs specifically directed towards areas of need and incorporating community leaders as instructors. Free brief trainings have shown to be an effective strategy to increase both rates of bystander CPR and self-efficacy levels. The Train the Trainer program, based on the American Heart Association's instructor course, with additional community components, is sustainable and allows for a multiplier effect of training to be achieved. It is affordable and easy for current CPR training locations to implement. Through this program, patient survival rates can be increased, patient outcomes can be improved, and overall healthcare costs can be reduced. And these are my references.